Okay, picture this. A patient shows up and they're bleeding, and it just won't stop. Your mind is racing through the possibilities, but for your boards and for clinical practice, there are 3 congenital disorders you're going to want to have right at the top of your list: Hemophilia A, Hemophilia B, and the one you'll see most often, von Willebrand disease. Telling them apart is a classic diagnostic puzzle, and today we're going to break down exactly how you can solve it.
We're going to tackle this like we're cracking a case. First, we'll survey the scene. What's actually going wrong when the body's clotting system breaks down? Then, we'll line up our main suspects, the famous hemophilias and the incredibly common von Willebrand disease. After that, we'll follow the evidence into the lab, and finally, we'll close the case with the right treatment plan.
All right, let's start at the beginning. Our bodies have this amazing, complex system to stop us from bleeding out called hemostasis. But what happens when you're born without a crucial piece of that system?
I want you to think of the coagulation cascade as your body's emergency brake system. When you get an injury, a whole series of protein dominoes, our clotting factors, are supposed to fall in perfect sequence to build a solid clot. But in these congenital disorders, one of those dominoes is just missing, or it's broken. The result? The brake fails. The bleeding doesn't stop.
So, that brings us to our first set of suspects, the hemophilias. You've probably heard of them. They're often called the royal disease because of how they affected European royalty. But what we really need to know is the difference between the 2 main types.
The key difference really boils down to just one thing: which factor is missing. Hemophilia A is a factor 8 deficiency. Hemophilia B is a factor 9 deficiency. Easy enough, right? Both are X-linked recessive, which is why they almost always affect males, and you're much more likely to see hemophilia A in practice. It's about 5 times more common.
Okay, get your highlighters out because this is a massive buzzword for your exams: hemarthrosis. This is bleeding into a joint space like a knee or an ankle that can happen with even minor trauma, or sometimes for no reason at all. It's extremely painful and leads to terrible joint damage over time. So if you see hemarthrosis in a question, especially in a young boy, your brain should be screaming severe hemophilia.
And that risk of hemarthrosis is tied directly to how severe the disease is. We classify severity based on the patient's factor activity level. If you have less than 1% of the normal amount of factor, that's severe disease. You're at risk for spontaneous bleeds. But if you have mild hemophilia with over 5% activity, you might only have a problem after a major surgery or a bad injury.
Okay, hemophilia might be famous, but our next suspect is the one you are far more likely to see. Let's talk about von Willebrand disease.
You know, it's easy to think of these as rare conditions, but get this. Von Willebrand disease is the single most common inherited bleeding disorder. We're talking up to 1% of the entire population. And it's so important to understand because it's totally different from hemophilia. It affects men and women, and the bleeding looks very different.
So what does this von Willebrand factor, or VWF, actually do? It has 2 critical jobs. Job number 1, it's the platelet glue. When a blood vessel gets cut, VWF rushes to the scene and acts like sticky Velcro, letting platelets grab on to form that first initial plug. So if you don't have this glue, you get that classic surface-level mucocutaneous bleeding, nosebleeds, heavy periods, and bruising super easily.
And here's its second, equally important job. VWF is also a bodyguard for factor 8. It literally latches on to factor 8 in the bloodstream and protects it from getting broken down too fast. So think about it. If you don't have enough VWF, your factor 8 levels are going to drop too. This is a huge concept because it explains why some forms of von Willebrand disease can look a lot like mild hemophilia.
Now, the disease gets broken down into types. Type 1 is the most common by far. It's a quantity problem. You just don't make enough VWF. Type 3 is also a quantity issue, but it's way, way more severe. You have almost no VWF at all. Then there's type 2, which is the odd one out. It's a qualitative problem. You might make enough of the factor, but the stuff you make doesn't work right. And knowing these differences is everything when it comes to treatment.
Okay, we've met our suspects, we know their MOs. Now it's time to go to the lab and find the hard evidence that's going to point us to the right diagnosis.
So you're in this classic clinical scenario, right? A patient is bleeding and their APTT comes back prolonged. That tells you there's a problem in that intrinsic pathway where factors 8 and 9 live. But why? Is it because the factor is missing, like in hemophilia? Or could it be something more sinister, like an antibody, an inhibitor, that's actively destroying the factor?
The way you find out is with a mixing study.
It's actually a really clever test. You take the patient's plasma and mix it 50-50 with normal plasma that has all the clotting factors. Now, if the APTT time corrects back to normal, bam, problem solved. It was a simple deficiency. But if it doesn't correct, that's your answer. It means there's an inhibitor in the patient's plasma that's still there, attacking the new factors you just added.
And this slide really puts it all together. For hemophilia A or B, you're expecting a normal PT with a prolonged APTT, and you're thinking about that classic deep tissue and joint bleeding. For von Willebrand, the APTT might be a little prolonged if factor VIII is low, but here's the kicker, it can also be totally normal. The bigger clue is the mucocutaneous bleeding. To really nail the diagnosis, you need to order the specific factor assays or a full vWF panel.
So we've cracked the case. We know what we're dealing with. The final step is figuring out the right treatment to stop the bleeding and prevent it from happening again.
Treatment strategy depends completely on the diagnosis and how bad the bleed is. For severe hemophilia, the answer is pretty simple. You have to replace what's missing, so you give them factor VIII or factor IX. But for mild hemophilia A and for type 1 von Willebrand, we've got another option for minor bleeds, and that's DDAVP.
So how does DDAVP even work? It's a synthetic hormone, and what it does is it basically squeezes the endothelial cells that line your blood vessels and forces them to release their stored-up emergency supply of vWF and factor VIII. It gives you a nice temporary boost that's often enough to stop a minor bleed. It's a great trick, but it only works if you have those stores to release in the first place.
And the story does not stop there. The future of treatment is just unbelievably exciting. We now have drugs like emicizumab, which is an antibody that can do the job of factor VIII. We have FDA-approved gene therapies for both hemophilia A and B that offer the hope of a long-term fix, maybe even a cure. And for those really tough cases with inhibitors, we have bypassing agents that can get the clot formed in a completely different way.
Which brings us to this final, really powerful question. For hundreds of years, a diagnosis of severe hemophilia was a life sentence of pain and spontaneous bleeding. With these incredible new treatments, are we right on the edge of a future where that's just not the case anymore? It's a pretty amazing thought to end on. Thanks for joining me for this explainer.